And so she went out and she had a pizza and she came back and her blood pressure was like 180 over 100 or something, and she had stroke symptoms, okay? She had elevated pulse. So we called cardiology or whatever, we got her some blood pressure pill and we stopped the MAOI. So that's why we don't give MAOIs. They will cause like a stroke-like syndrome. So if your patient is stroking out on a medicine and you know that medicine might have caused those stroke symptoms, do you just go ahead and give it because it was the doctor who ordered it at 9 a.m.? No. You always have the right as an RN to hold a med and tell the doctor you're holding it and report the vital signs and report the concerns. And in the case of something more serious where there's really stroke symptoms and you're in a hospital, you might have to press the code buttons and have the stroke team come up. When you're out in the community, that's when it's really scary because there's no button you press, okay? What it is you gotta keep their airway open, you gotta take the vitals and call the paramedics. Now, if your paramedics come quickly, you're great, right? But if you're in downtown San Francisco at 5 o'clock and you're in Harrison and there's like all this traffic, which has happened to me in a detox that I used to run, and people are seizing and vomiting, it's a little complicated to get them up the hill in St. Francis, even though it's the hill, right? But that's what community health is like sometimes. You really have to be a risk taker and be independent. There's a lot of resources in the hospital. As long as you make good judgments and people trust your judgments and the doctors get to know you, you'll be fine. But if you're just like, oh, I just gotta go home at 9 and I'll just look at this computer and I'm just gonna coast, you know, and then you walk in your room and your patient's dead. Well, you know, that's the end, right? So people have to, that's why they're into all this clinical judgment, because they've had a lot of issues, and it's not all the new nurses' fault. We had COVID. We have hospitals that are very rigid about letting you in there for experience. But get yourself a good, take advantage of your clinical when you're in med-surg. Really assert yourself and take advantage, because otherwise you could just sit back, and then if you think you're just going to walk into a hospital and know what you're doing, you're not. You're going to know how to take these exams, but until you actually see the patient and know these things with seeing it and the theory and applying it, and then all the tactile stuff that we have to do with different procedures. But it takes time, and it's totally fine. But the bottom line is, as a nurse, if you don't feel comfortable, if you really feel like something's wrong, the medication dosage is wrong, someone's having a reaction, doesn't matter what the old nurse next to you says, oh, go ahead, just do it, you know. You have the right to, like, not do it because you know that there's something wrong about it, right? And you call the doctor and you stop it. And believe me, I've had to do that many, many times. You know, you can't just read things literally. Even with the computers have helped so much. They really have in many ways. Because before it used to be, when we got the doctor's orders, you know, we were solely responsible for it. There was no check by the pharmacist first. It was a red pen on the night shift, okay? And it was paper. But now, the pharmacist checks the meds first, then you check it. But the pharmacist still can forget things, and so can the doctor. The pharmacist still can forget to put the right medication in the little slot in the Pyxis. So you have to always slow yourself down and really pay attention to what you're doing, because things move so fast and people are pushing you all the time. Any questions? Yes?
Okay, so to think of benzos, anytime, what questions give us, like, the drug name and its,
I think on well, let me tell you, on NCLEX or Hesse, it's going to be all generic names.
generic, thank you.
It's not going to be Zoloft or Prozac.
But then
okay?
I could know
But-
those are benzos because it ends in pan.
Yes, that helps, like diazepam, lorazepam, what's Xanax? Citalopram. So those are usually benzos, yeah.
And then,
With the tryptolines,
yeah.
it's usually those old tricyclics.
And so what are those tricyclics used for?
Chronic pain and depression, they're more sedative. Yeah. They're old they were the first really antidepressants we had before the 1980s.
I still see amitriptyline used a lot though.
It's good for chronic pain, like if you have neuropathy pain.
Okay.
Yeah, in neurology you see it more. It's sedative. It'll help you sleep. It helps with
I just see
pain.
it constantly in like my job. I just see it constantly.
Where is that? At the skilled nursing?
No, I work at urgent care where we do medication
Really?
reconciliation.
So it's made a comeback.
Well, I see it all the time.
Really?
So it's like it's a very.
I would like to know the age of the people taking that.
Oh, they're
Just-
older. They're like
Yeah.
between 60s.
Well, that's the thing. See,
60s.
they've been on it for so many years, they're not going to change it.
Yeah. Okay.
And it probably helps with their chronic pain if they have it.
Yeah.
Okay, so did everyone take this quiz yet? Did you want to go over this quiz real quick?
Yes.
All right, let me make sure. There's a person in here that hasn't taken it. Is Chris Castillo in here?
No.
Who is he? You know? Oh, he was the first presentation. Oh, I remember him. Yeah. Okay. Maybe he's just out and about. Okay. Well, he's not going to be able to take this. We'll have to. I'll make another quiz for him or something. I'll have to check in with him. Is he okay? Does anybody know him? He's just like disappeared.
He was asking about what do you call the other class? Health assistance, but he didn't mention anything.
Well, we'll just have to deal with it.
I'm trying to get all of it. I started
Okay,
yesterday.
so
Yeah.
Tiffany,
I mean,
all
the
right,
review.
so this is a Tiffany question. So why would assessing the bleeding hands be important too?
The difference?
It's a
Can be under assignments. You
Yeah,
do,
right.
you can just put assignments without
Actions,
clicking.
so
You will
it's
find the
two. Okay, select the best answer. Why wouldn't you say to her, oh, just stop it now, I don't want you to do
without
that?
clicking.
because it's not.
What's that?
I see, is that how the exam question is going to look like? Something like
Yes, yes, yes. So, do you think that if you told her, get out of that bathroom or else, she's gonna come after you big time? Because I've had nurses do that kind of stuff. She will be like, open that bathroom now, you know? Because that's how she contains her anxiety.
The quiz.
Huh?
The quiz.
This is the right answer, yeah. Introduce yourself to the patient. Check the hands. If they're washing a lot, they can really rip their skin.
Okay.
Right? But you're not going to, and this is process of elimination, right? Which you got to do a lot with these exams. So you go through it and you say, lock the bathroom door is definitely not, even though you would like to do it because you're busy, you know, lock the bathroom door is not going to work. Yelling at the patient is definitely out of the question. So you know it's a select all, so it's got to be these two, right? So sometimes if you're not sure, just do process of elimination, especially with all these. So when it's these boxes, it's select all, right? When it's the circles, it's only one answer, right? Go ahead. It'll take half of a point off if you get one of them and not the other.
Go for it. Your question?
So why? So for this,
The same, am I sure assignment?
for this next one, it's Why isn't auditory hallucinations or command hallucinations part of OCD? You know?
Without opening, you couldn't see?
Because these are psychotic symptoms. These are people that have schizophrenia.
Really?
This is more of an anxiety disorder, so it's going to be sleep. Yes?
What about like dissociation? Wouldn't somebody who had OCD be dissociating, like doing their practice?
Nothing else.
But when you go out, it says the same thing, but when you go out, you're shocked.
Well,
Doing their ritual.
is common is really going to be anxiety with those things. Yeah, but you could say that they're dissociating in a way because they're so busy washing their hands. She's not dealing with bereavement. But that's not really what they mean by dissociation. They mean like under the influence or, you know, altered is usually under the influence. Yeah. But you're right, there is a dissociative component to anyone that's doing a lot of that rituals, which is a little different than this, because this is like, you know, I'm delirious, my potassium's off, or I'm taking drugs, or I'm, you know, I'm altered. Which drugs are serotonin reuptake? So this is easy. It's not olanzapine and Haldol. We haven't even studied those, right? It's got to be these two, right? It's a select all, so you can't just choose one. So it's Prozac and Zoloft. Okay.
I didn't see the first question.
You didn't see the first question?
No, I couldn't see that.
I'll open this for you afterwards. Even though Chris is going to have to take another quiz if he doesn't make it. So this is, you don't want your first action to be stop it and lock the bathroom, okay? It has to be make sure they're not harming themselves with infections or introduce yourself. Try to, you know, we usually try to distract people that are engaged in rituals. So the benzos, it's GABA, right? It's not anticonvulsants or any of these other things.
Well, we need to know barbiturates for
Not this exam, no. That's an old thing, barbiturates. I'm trying to think of what phenobarb is a barbiturate, right?
Yeah.
So we use that mostly for seizure disorders.
Oh, really? Okay. They're not anti-anxiety? No.
No. You get addicted to it,
Okay.
I think, if you took it for anxiety. You know someone taking it for anxiety?
No, I've always seen benzos and barbiturates grouped together, so
Huh,
I think-
interesting.
yeah.
Well, find me where you see that, and I'll take a look at that. Yeah. Okay, first mental health nursing priority is always safety. And so for this person, because she said she thought of ending it all, you have to ask her what she means by that. And then, you know, you're never gonna end her obsessive behavior by locking the bathroom door, so that's out. If you call the doctor for an increase of Ativan, when she starts to express sadness over her father's death, that's kind of lame, okay? Because you're medicating someone's grief in a way that's counter-therapeutic. Yes?
What if the OCD ritual is some type of self-harm?
What did you say?
What if the OCD ritual is some type of self-harm? Wouldn't you want to stop that ritual if they're hurting
Well,
themselves?
yes, if she was cutting constantly, you could try to stop it. But if hand washing, should be okay.
So it'd be something more severe that's actually like dangerous?
Yeah, like constant head banging, but even with that, like you would have to, we give people helmets. And we give them medication for it. But usually OCD is more anxiety related, you know, with hand washing, showering, germ phobia, cleaning, right? So the reasonable discharge goal is that because her OCD is related to the loss of her father suddenly, you want to make sure that she's going to have some opportunity to address support for bereavement. You can decrease her hand washing, but after 5 days, nobody's ever going to be 100% cured, but you definitely can't let her out the door if she still wants to kill herself, right? So, and the signs of the major depression, we've gone over that, so you guys know all that. And we talked about the Wellbutrin with that case, so that's very good. And we know the triptylines and the impramine are all tricyclics, and they all have cardiac side effects, and they can help with chronic pain and depression. And they are not antipsychotics. So it's always important that if someone runs out in the middle of a hospital space and they start getting out of control, get everybody out of the way, other patients, and try to respond. If you call security immediately, what could happen if someone's just yelling? Yeah, they're gonna see a bunch of blue uniforms, right? And what if they've had run-ins with officers, and these officers, hopefully they're trained, sometimes they're not. And it could be a mess when all you had to do was really just check in with them first. And now, you shouldn't go in a room alone with someone like this, and you should have your coworkers be available if they have to call security. You can offer medication if they need it after you check in, offer them choices. Stop yelling, I told you the doctor is busy. What's that gonna do? They might knock you out, right? Okay. When the nurse says, the patient is so sweet, she reminds me of my grandmother, according to Freud, the nurse's statement may reveal unconscious projection of past experiences and produce blurred boundaries that's called counter-transference. When it's the nurse, it's counter. When it's the patient on you, it's transference. If a patient is displaying these behaviors, you know they're depressed. If they recently had an overdose, if they're isolating, if they're very tired, if they have the antidote. Okay. So these are the medications. When Gloria tells the clinic, I can't go on like this anymore, she comes up for her annual checkup, the best therapeutic response is ignore it and hope that she will feel better later in the day. No, we know that's, so you do process of elimination. You can do it, keep working hard. Well, sometimes we're tempted to say that, but they don't want to hear you say that in NCLEX. Sometimes we do kind of give people pep talks a little, but this is the most important thing, is how can I help? Is there something upsetting you? It's like if you just don't go to the root of the problem and you just kind of give them positive reinforcement, it's not so great. And you have to always empathize or relate with it. It sounds like you're having a difficult time. The patient yells out at the nurse's station, I want to see the doctor. The most therapeutic response is pipe down, I'll call security. No. Right? That we can X that one out, right? Send in the mental health worker to deal with it. Probably not the best, right? Ignore it, there's nothing you can do, right? So those are all bad. Okay. The patient begins banging his fists on the medication window, yelling, I need my pain medication. If you don't get my medication, I'm going to walk out of this place and buy it on the street. What are some important considerations? So this actually happened to me not too long ago. So what would you do? Well, you definitely at some point, this is multiples, right? So are you going to call security immediately? Well, it's kind of scary when they're banging, so you shouldn't take it that lightly. However, don't do it immediately. First, have someone with you and do all these other things, right? But if you don't address the underlying thing, and if it is that they actually do need some kind of medication, even if it's not, there's a lot of non-narcotic pain things, right, that doctors can give, other than saying, I'm not going to give them anything. Because guess who's going to deal with it?
No.
It's not going to be them. They're going to walk away. So, do you know about the pain teams that they have at some hospitals? Pain teams.
Oh, the pain.
Pain team.
Oh, pain team. Oh,
Pain
yeah.
team. Do you guys have pain teams? Yeah. Can you talk about that, what that is? A pain team. People that have chronic pain, you can make a recommendation. Maybe they should see the pain team. Everything you give doesn't work, right? And that way, because there's a lot of things they can give for pain, like Cymbalta, right, which is, or even a tricyclic if they have to. Or there's things like non-narcotic analgesics, Flexeril, right? I can't think of all of them, but they come up with new ones all the time. Like gabapentin you can give for certain kinds of pain, and it helps anxiety. But if they just let them, oh, it's a drug addict, I'm not going to deal with it, this is what you get sometimes, and it can be really dangerous. Okay.
So pain team is like
A pain team is sometimes a consult service. So you have consult services in medical centers, right? Sometimes you have like an endocrinology team because we have tons of diabetes, right? Or you have a like psycho-oncology at UCSF. They have psycho-oncology where people who are recovering from cancer have a lot of mood changes. They're on chemotherapy and things. So there's a whole psychology department devoted to people who have cancer. Okay. So there's, it depends what kind of place you work, really, because the bigger medical centers, like Stanford and UCSF, they're going to have pain teams, and they're going to have more contemporary things. Where if you're in a rural area or a low-budget place, you're going to have to be more creative about it. You might actually have to make recommendations to the doctor. Have you thought of gabapentin? Have you thought of what are the other non-narcotic things that we can try, right? And if the doctor likes you, they'll appreciate that. But if they're not open, then they're not open, and then you get a problem. You got to talk it over with your team. So medical triage, is really something that happens before they get to the psych hospital. The pregnancy test, the tox screen, the history and physical, right? So all of this, getting the weapon, this is usually before they go to the freestanding hospital. So I just put that in there for your own knowledge because some of you are going to work in the emergency room. And because you took this class, hopefully, you're going to be like, don't just dump that psych patient over there with kidney enzymes that are crazy or blood alcohol that's out, because that's what happens. I've had people come with end-stage kidney disease. I've had people with concussions. I've had, unclear cancers sent to the psych unit because the ERs are so busy. It's not entirely their fault. But there has to be some clarification about where this person is going to go after their depression or their psychosis is cleared. Like, if you have lung cancer, who wants to hang out in a psych unit for several weeks because you have some dementia and you're old and you have no one to advocate for you? And that was a patient. And I really was upset about that. But I only could do so much. And you get that. When people don't have someone to advocate for them, they're more vulnerable in our system. And if they don't have a lot of money, they're even more vulnerable. Yes?
It says higher PES, so the PES is the emergency room, so what is prior, how would,
Oh, PES is a psychiatric emergency room.
so it's prior to PES would be what? Just
The medical emergency room.
Okay.
So you always, you want, like I will bring you, especially for you students that don't have the opportunity to be in the hospital, you should all see, because this will help you with your health assessment course as well. You should all have, and we don't have hard copies of things anymore, but I'll figure out when I'm at CCMC, there might be a way to get it off the system more. But you should see what the admission forms look like when someone comes in the hospital for a psychiatric or medical thing. And they might be
Maybe
different
something happened.
depending on where you're working. Like if you work in OB,
So,
you're gonna
we
focus
do this
more
here,
on obstetrical
this
issues,
program,
right,
but
on
when
your
you go
admission
there,
form.
you do this.
And if you
Only
work
for
in
this part.
psychiatry, they're gonna ask you
And
more
it's
about
5 and 6,
mental health
same way.
histories,
But
right?
This is different program.
But
That's
generally
different.
speaking, there's always a head-to-toe kind of
That's what happened
assessment
when
on
we
there.
were
There's
the last second
allergies,
before.
there's
I could
lab,
submit,
you
it
know,
said
medical history,
5,
what
25 and
medications
6
were you
months.
taking at home. So you should really see that, because I think
They were very simple.
that's really
5 and
helpful
6.
to see like what. And so when they're in the ER, they want to make sure that if they have drugs or alcohol in their system, or they're pregnant, or they have like really bad hypertension or cardiac disease, they don't send them to us, because there's no doctor that's going to be working up their cardiac disease or diabetes extensively, although we get tons of diabetics in mental health because of our antipsychotics, and we'll be talking about that. And you know, the cool thing about diabetes now is people, well, there's nothing cool about diabetes, okay? But the cool thing about it is people have those little monitors, and they can, yeah, it's like, but I want to know how much all this stuff costs, because I never see
Got it?
homeless indigent patients walking around, right? And those are the ones that you're going to have to be doing the finger sticks and titrating the insulin and all that. And that's really hard on people after a while, because you're sticking them 4 times a day. All right, so
This really helps. I mean, extracted.
so the nursing diagnosis, have you gone over this in health assessment yet?
Then
Okay, so that this is the issue. Get a NANDA book or look up NANDA on your computer, because you're not going to see it in the hospital. You're not going to see like risk for suicide. You're going to see suicide attempt if the person made it, or major depression. So we put the medical diagnosis in the EPICS with their own care plans that they usually have, master care plans, and then you just click the box and you pull down whatever is used at Stanford or UCSF or whatever doctor you're working under, right? They usually have preferences. But in nursing school, they still are with the NANDA. So why? Because they think it focuses more on the nursing problem than the physician problem, which I don't think that's true anymore, but there's nothing I can do about it, so I have to teach you this, because they're gonna ask you questions about it, right? So ineffective coping and risk for suicide are really what we see a lot of. We see a lot of ineffective coping and risk for suicide as NANDA diagnoses. Risk for suicide is evidenced by thoughts of shooting self with guns. So they always have as evidenced by, yes.
I was just a little confused by like I think I did click on that one, but with no family or friends, because in the case study, it does say he has family and friends, but is it the isolation?
Yeah, it's the isolation. Yeah.
Isolation, so it's
Yeah.
social isolation
Yeah.
with no family or friends.
Yeah.
Not that he had no family or friends.
Yeah.
But-
So ineffective coping and risk for suicide is, well, he has one daughter that's out of state. But I mean, if you want, I can all give you a point for that
Well, it was like
question.
I'm
Just
saying
be-
she's wrong.
But what you should know is these are very common, like they're gonna ask you for nursing diagnoses and HESI and NCLEX questions. So for serious depression, those are common. The other thing, social isolation with the elderly is big. That's more of it. We don't really put people in the hospital for social isolation alone unless they have major depression. But outpatient treatment, social isolation is a big deal because we want people to go to support groups, especially if there's been bereavement or just things like the self-help groups, you know, social isolation, hopelessness. They're going to ask you a lot of questions. Is hopelessness a problem? They're going to ask you that for depression. What do you think? If you're hopeless, why is that problematic? Right, there's no future plans. So you can't go there. You can't even go there in your mind if you give up hope. So when you take hope away from people, you're taking a big chunk of their future away, right? Or when they can't even think out of their box because the depression is so debilitating. When Tom arrives, it is important to remove all the sharps. We have a sharp closet in the mental health units. Shoelaces, belts, glass from people that cut, cigarettes, lighters. Has anybody seen that stuff? Right. And then they make a list of everything, of the belongings, and you return it. Razors are always a big deal, and a lot of guys want to shave with regular razors, and some of these places only have regular razors, so sometimes when they feel better, we'll watch them, but it's always stressful for me when someone's shaving in there and they've been suicidal and they have a razor. I always like it when they have the other kinds of razors. So the problem about medical, surgical, and ICU and all this, they're not wanting people when they come in your medical centers. They're not, people can walk in with stuff, okay? So, you know, I took care of, this was a long time ago too, like maybe 20 years ago, this grandma had a snub nose in her purse because she was afraid of the people coming after her son. She was sweet though, luckily she didn't harm any of us, but we were a little uncomfortable with that. Or I've had patients, you know, bring narcotics in to patients and slip them stuff, like through their IV port. Yeah. So you have to, if you're uncomfortable, if you're getting that vibe, you know, about visitors and stuff, don't tackle it alone though, because Granny might pull a or someone might hurt you, seriously. So in mental health, we have security, we have trained personnel, but it's not always the case in med-surg. So it's best to huddle with your staff and just say, you know, something's going on in that room. I'm not quite sure what it is, but it makes me a little, can you come in there with me? I'm not going to go in there alone, right? Because you don't want, you're more vulnerable because you have IV poles, you're not wanting people. It's unfortunate we have to even think about that, but you do. And you have to think about not being alone with someone, especially someone that's threatening or unpredictable. And family members, they can be difficult. They can be much worse than our patients because they'll be like, why didn't you do this? Blah, blah, blah. And you're really busy. Like in medicine, it's a different pace than mental health. It's feast or famine in mental health. You'll have a few patients that are causing all this disruption in mental health, and you're always trying to like stabilize them and keep them out of other people's rooms. But in medicine, it's like, I'm busy. I've got like all these things I have to do, you know, at a certain time, and then you're going to have to refer those people to social work or patient relations or something, because you don't want them to feel like you're not listening to them. And it's really challenging if they're really upset. And it's usually like the doctor hasn't called me, I've done a million phone calls to the social worker. No one, or they're on the phone doing that with you, and you're like in the middle of a med pass. You know, they're like, no one gets back to me, I've left 5 million messages, you know? And you feel like you're in an ethical dilemma, right? Because it's not right, and you know it's true because the social worker's overloaded or whatever. So if you work in a place that really flows well in those areas, it's going to make your life a lot easier. Okay, let's see. So we talked about the Ativan and Wellbutrin, so I think we're all caught up with that. So I think we're pretty much on. So I would suggest, yes, go ahead.
Professor, are you going to have the select all the applied questions on the
They're so
exam?
cute. A few of them.
A few,
yeah.
okay, so. if
People
they
think
come
my quizzes are more difficult than the exam, and I'll tell you why I think they probably are. Because I want you, it's the first time you're exposed to how that's set up, that's all it is.
Second part of my question, if we
Yeah.
select only 2 correct, if we select all the applied, are we getting points?
Yes.
And if we select 1 wrong, then it's wrong, right?
No.
No, okay.
I
We're still
think
getting
you
the
still
good
get
points
partial
for-
points
okay,
for the
good.
ones that are correct, yeah.
Yeah.
So does everybody have the big thing, I'll send out an announcement. Now, the TAs are very good, okay, because I did not, these TAs I had last semester, they're in their second year of ELMS, and they're going on to be the nurse practitioners or the case managers. And most of them really like the mental health, and they did well, and they're just like these brainiacs, a few of them, so just follow their lead. They'll come up with stuff that I won't, Like the fill in the blank thing that she devised, I thought was really helpful. If you're if that works for you. And sometimes with meds you can make a chart for yourself, like these are the meds Professor Polito mentioned, these are the SSRIs, these are the MAOIs, these are the gabapentin and the lorazepam, addiction, oversedation, no chocolate and cheese, serotonin syndrome, sexual side effects, cardiac problems with imprimine or overdose fatalities. The other thing about antidepressants, they'll ask you a lot in these, if you go on Quizlet or something, you're going to see some of this stuff. But I don't know, they're changing up their questions here and there. But another thing they'll ask you is, Jane just started her Zoloft a week ago, and now she has nausea. Should she just stop the medication?
No.
Right. Another thing they'll ask you is, suddenly Bob is giving away all his possessions, and he wants to leave the hospital, and he feels like he's on top of the world, but nothing in his life has changed. What would you do? Make a suicide risk assessment, because sometimes people want to kill themselves and they feel relieved and they'll start giving stuff away and they'll get energized by some of these drugs, not usually SSRIs. Sometimes Effexor will work quickly. Wellbutrin will work in 2 weeks. Effexor is more potent, so maybe the initial burst is a little quicker, I don't know. But everyone's system is a little different, so some people swear, I can feel this in 2 weeks. And maybe they can feel something. But they say the peak is 4 weeks. So if people have been on these medications for a while, they get a tolerance to it. Right? So they can have higher dosages sometimes, where other people, really low dose might work for them. But they're not going to ask you that because that's too complicated for testing your endpoints. Right? They're going to ask you about ECT maybe as an operative procedure.
What is the ECT movie? I saw that It's on the study guide, but what is the movie? It says review ECT movie.
Well, I can download one. There's lots of ECT movies. I think I had one on there and took it off.
It says, what is the pre-op checklist? How many questions are you gonna ask us on ECT?
About 2 questions on ECT. And some of it has to do with pre-op, and I have an OR tech that's in my other class, and she told me people are still, and it's not ECT they're doing this for, nurses are still giving people food before surgery. Why don't you give people food? Why are they NPO? What? They're gonna die, right? Or aspirate. Why would a nurse be afraid to tell the surgeon
So you get partial.
or the doctor that
Higher?
they're afraid they're gonna get fired or something? No, you're not gonna get fired. They have to reschedule the surgery, that's all. ECT, sometimes they could do it later in the day or something. You're not necessarily gonna get fired, okay? So, notify the doctor, hold the procedure. Let's see, what else is there? Anything? ECT is a seizure, right, that you're inducing, so you want to make sure that they're off any kind of anticonvulsant, because anticonvulsant means you're taking your Dilantin or your Depakote to stop a seizure. So the ECT is not going to work if someone has a lot of that in their system. So usually they take them off before the ECT. The other thing is the magnet, the transcranial.
Transcranial magnetic.
I don't think I have a question on that, but it is kind of interesting because it doesn't have the NPO after midnight. It's just like this magnet that actually stimulates electrical currents. And I know the VA does a lot of it. I don't know if UCSF or Stanford is doing it. I haven't read. I heard it has some good effects, so, but you might come across it if you're interested. You should probably look it up. But that's really about it that I can think of, and I hope that was helpful for you. Okay. Electroconvulsive therapy. So basically, they're putting these. Actually, there's paddles involved. Okay. And they will stimulate a seizure. People can jump right off the stretcher from it. Have you seen it or no? So yeah, so that's basically it. And it's usually not the first line of treatment for depression. It's more for resistant depression. But sometimes people like it because it works so quickly and it doesn't have the sexual side effects or the weight gain or all these issues with the antidepressants, but people have to still be put on medication usually, even if they're doing ECT. Okay? Is that it? So I'll bring up, yeah, go ahead. It's NGN. Yeah, it's the Shadow Health is in SurePath. So if try to do it, okay? I can give you extra time. If you have time to do it, it's probably helpful.
What's that?
But Shadow Health, yeah, it's probably helpful. But it takes like over an hour sometimes. 2 hours, yeah. Says it's a simulation. Have you done any of them? Yeah, try it. Look like it. It's a little robot.
That one takes more time.
It'll help you.
I did one, which was
It'll help you
easy.
understand how you
The other
talk
one
to
is
patients. Yeah.
depression. That was big.
If you don't
This
think
one,
it's helpful,
yeah, this one takes more time.
email me and say.
Anxiety engagement.
Yeah.
Started it already?
No, I did not, but I checked on Discord. They were saying it takes a lot of time.
Well, mood is something that you should know what it is in general.
Okay, down depression. No, not this one like that. Now, this would take time, massive, but she said do as much as we can. You don't have to go all
What is it on communication?
Yeah, communication, massive. EAQ massive. Because I think we have to go around 50. Assignment? Yeah, this one. No, this is I did first part. I'm not sure what I'm learning from this book. Just don't go just on the study guide or the slides. No, try to get beyond that. Because they always be asking confusing questions. So knowing this will not only help. I mean, this one is easy, but kind of I asked the assessment professor, and she was like, don't waste your time on the study level or something like that. Just go and study guide, slides, here and there. So don't waste your time doing the master level. Yeah. Because they keep saying that whatever, right?
So I don't think.
Like what we need to do, like just in line.
Oh, yeah.
Go to just in line and do your own research, YouTube or anywhere to find more about it. Because they're gonna be asking more around that topic. Yeah.